you often hear, oh, there didn't know there was natives in New York, but there's actually quite a few in New York. And then straddling across the river before U.S. and Canada were here, our populations are significant. But I'm also the director of the Center for Indigenous Cancer Research at Roswell Park Comprehensive Cancer Center. Roswell Park is an NCI designated standalone comprehensive cancer center, and it's the oldest cancer center in the United States, founded in mid 1860s. So it's been in existence for quite some time. I always put this challenge out there too because I think it's really important that to understand what is the strategy for NCI designated cancer centers in Indian country. Is there a strategy? What are the tribes in the region of the so-called like catchment area around cancer centers, and what has the relationship been, or how is that sustained over time? And from a more macro perspective, I think that's really important when you talk about cultural competency. Relationships are part of competency. Building relationships and having strategic plans are part of that macro level cultural competency. And I think that word too is really interesting in its own way, because how are we ever competent in anything, right? We always hear that from our elders, like we're all, even as I guess I'm a junior elder now, but as you're getting into your elder phase of life, it's always a learning. You're always learning. You never stop learning from a baby. So you really can't be competent in everything. And culture is so unique in its own capacity that we can only strive towards being understanding these nuances and the way we interact with each other. So, that's part of I think the conversation today. So, but I'll turn it back over to Dr. Roybal if you want to initiate some questions or if you have response to any of those things.
And no, thank you. No, thank you for that background. I'm pretty excited that we're crossing a lot of these Western state boundaries, right? To really seek out resources and learn from what you're all doing in New York and what we can do here in New Mexico to provide what you're doing in Arizona and the availability and bringing that knowledge here. We know that we have some of the greatest disparities. We have really, native communities in the state of New Mexico are more likely to be diagnosed later. The survival rate because of that is also shortened. We're seeing a lot of these, just major disparities among several of our pockets of corridors. Some of our tribes out like around the Navajo Nation have a lot of uranium mining, extractive industries sites that are really affecting the health. And so reaching out to you all to kind of understand, like, how do we bridge this, break down those barriers, and how do we bring, comprehensive, care to our communities here, and just kind of open all of that up. I want to talk about really defining the problems. We know that disparity is there. We know that people are less likely to, they're going to be diagnosed later. There's a lot of different issues going on. We have a lot of childhood, early childhood cancers, leukemia, breast cancer. We have some of the highest rates of breast cancer among women, Hispanic women in the Northern Corridor. And there's a lot of different pieces going on. And so I just want to really talk about the problem that we're seeing with your experiences and of how it's impacting communities that you're looking at, and kind of why you got into this build, right? You probably saw this, you probably, that drove that kind of passion moving forward to think about solutions, and then how we can just bring those solutions and start to kind of build something here in Mexico, thinking through. We did reach out to some of the centers here, or tried to reach out to some of the centers here, but we've had a lot of community that have connected with us, and some other practitioners also to try to find resources for tribal communities. Right now what they're seeing is that a lot of the members are coming from these areas that are highly affected, but there just isn't the resource. So let's just back up, and I just want to talk about the problem, kind of defining the problem based on your experiences, your pathways getting there, and how it's impacting
Yeah, I think from a clinical perspective, it's a very multifaceted problem. I think you touched on a couple of things. I think one of them being is that within our populations, within Indigenous populations, this is largely seen as kind of a Western disease, and there's not even necessarily verbiage for us to describe what's going on. So there's already a knowledge gap between what you can communicate and kind of what is understood from a patient perspective. Because a lot of cancer and being successful with cancer is trying to catch it early. And that's where the preventative cancer screening comes in, where it's mammographies for breast cancer, colonoscopies for colon cancer, things like that. If patients don't really have the understanding of why they're getting these screening tools, and they think, well, if I do that, I'm going to get cancer, and I don't want to know that I have cancer. And really the idea of them is to catch it at an early stage where it's really treatable. And I think there's a real gap in understanding about preventative care, but also the fact that a lot of our populations live in very rural areas. So to actually get those things, it's a challenge. People either have to travel to services, or somehow those services have to get to the patient populations in rural areas. So there's challenges in both ways. And then when people get diagnosed with cancer, even people who are, very educated, it's a big diagnosis, and a lot of people don't understand it. Each cancer type is different, and so there's a lot of different understanding, even just within the different types of cancer. So it's a vast problem, and I think the other thing that really contributes to our patient population specifically is that we do have a lot of turnover in providers. There's just not a lot of investment of, like I said earlier, every time I went to the physician, it was somebody new. It's hard to get problems solved if every time you're going to the doctor, it's like a blank piece of paper again. They're kind of working from scratch. And so to get continuity for people who are invested in those communities to stay and really try to determine what the problems are and what is really affecting Indigenous populations is part of it. And I think a lot of the research that Rodney and myself have done in the past is really just trying to get to the point that you're saying, is really defining the problem, because a lot of the cancer research within the United States doesn't specifically look at Indigenous populations. So we don't even know, compared to, non-Hispanic whites and other populations, how it exactly affects our communities.
I'll add to that by saying, it's really important for communities to take charge of their data too, and in the context of using data for understanding the need for what the trends are, mortality rates, prevalence, incidents, things of that nature. Tribes have this sovereign ability to create their own kind of epi profile of data, what it looks like to them, and how the tribe can use it, or how communities can use it beyond the tribal context. A lot of our community partners also have that ability to create their internal program evaluation. And by doing that, you can identify areas of need. We've done that in the past at a more macro level, not to identify tribes, but look at regions, for example, across the Northeast, of ancestrally related tribes and what those patterns are like. There's a need for it to be continually done too, not just a one-time deal and that's the way it is, but to update the data and the reports or the papers, whatever it may be, on a kind of a consistent basis, so that we can see changes in our communities. We can see what's working, what's not working, and that's really important. You can have cancer prevention programs or other types of intervention, but if you don't know if it's working, then how do you know you're making change? You could be implementing something every day and not doing anything, or doing something that's not very helpful, or it's not addressing the concern. So that's really important to understand too, is how do you take control of your own data? How do you work with university partners, how cancer centers, whoever it may be, they have a relationship with, to really move forward and understand your community in that context. And we also get that question, I do, I'm sure Dr. Heiser does too, is, what's the cure for cancer? You're doing this research all the time, and that's I would say screening is definitely, if you look at it in a cured context and as a prevention type way, screening is definitely an important aspect of, part of that kind of cure philosophy, I suppose. The earlier you can get detect cancer, the better options and opportunities you have to attend to it. So early screening is really key in our communities, and that's one of the stats you see amongst all minority communities, that we usually don't get screened earlier enough, and we're in later stage by the time we find out what's going on, and treatment options are less. So the importance of cancer focused patient navigation in our communities is key to that medicine to attend to whatever it may be happening in our communities. And the communities, when you have patient navigators, they're on the ground. We've created a program that is like co-housed, where they have some time on campus at the cancer center, and they have a majority of time in the community doing community-based outreach, encouraging screening, finding out or educating community members and leadership about what screening is, and is that that kind of allyship and communication and working with the communities directly is really important.
You made me think of two things. One is the data. Like, what individuals, I'm always thinking through, like, how do we build comprehensive data systems that are going to help overcome? So there's a lot of disparities, right? Just even having medical doctors in the field that are, working on tribal reservations or off. We know the state of New Mexico has a very limited number of nurses, like we're always short, trying to locate. And so I'm thinking in, like you said, the continuity of care, you go in to the doctor's office or to IHS or different, you always have a different provider. And so thinking through, how do we not walk in every single time with a blank sheet? And I'm thinking individual data and data sovereignty, how far are we from actually creating data profiles that individuals can actually carry with them? I mean, would that be something like the solution? I'm just thinking through, like, how to carry. I know in other countries we're looking at different types of like data systems so that every individual carries their personal health data with them. So say that it's a new doctor, they actually have, and that's data, that's really like around data sovereignty and really being able to own our data, right? Our data kind of stays within a program and a file here, and we have to wait till somebody else trains it. But as tribes and as sovereign nations, we have the capacity to own, like personally own and bring that data back into the tribe so that, you wouldn't have a blank sheet. You would have all the tests and everything else that were done. Just different ways to use the data to make, to create continuity of care outside of the medical system, because that's a whole other challenge, right? Just having providers that continuously provide within different service areas without changing. So I'm just thinking of like different types of solutions, but have you ever discussed any of that, Rodney, or have you guys thought about?
Yeah, I'll provide the segue for Dr. Heiser to complete the storyline. But I think that there's two types of data, right? And tribes have to have this education too. The first type of data is research data, where you come in to create a research project. The data is protected at the government to government oversight. There's a whole ethical paradigms around the use of that data and how it's shared outwardly to the public and to the world. The second type of data is more what you're talking about, is clinical data, and that is not research. It's part of the individual profile of their health data, for example, and how that's used in a clinical context. And by having clinical data and working in outside of the research realm, but in the service context, provides information both to the community for screening, for time to screen. Hey, it's time to screen, or maybe it's data that informs, boy, you might need surgery. And so that kind of, I'll pass it off to Dr. Heiser. But that's kind of like the clinical side of things. I think is really important to understand those two different types of data and the work that we do.
Yeah, and I would say that there is some, I guess, crossover in certain contexts. So for cancer specifically, there's a research database called the National Cancer Database, and that's largely hospital-based. So people who go to hospitals kind of pool all of their data into one thing. It's all declassified, so they can't see, you know, who the patients are or what race specifically, aside from just the generic, you know, American Indian. There's no tribal identifier with it. That can give you some idea of what's going on in the clinical setting, but there's a lot of flaws with that because a lot of that is misclassified. So people who are actually not Indigenous are classified as Indigenous just based on you know, whatever the person who did the intake had marked on their sheet, or because they didn't mark their sheet, they're just classified as non-Hispanic white. So you get a lot of, you know, misclassification of data within that. And I think to go back to your point about really sort of how to get ownership of that data again, I think on an individual basis from a clinical perspective, it's vitally important. And I think that's one thing that everyone can do is to actually take ownership of their own information in terms of really asking questions and writing things down when you're at the physician and trying to figure out what exactly you've been treated for, why you're getting treated for it, what drugs you're getting, why you're getting those things. Because often people just show up and then they'll say, oh, I'm on these drugs for, I don't know what reason why. And that tells me that they have no ownership over what is actually happening to them. They're just letting these things happen to them. And I think that's also just, you know, part of historical trauma of things that had happened to Indigenous people, you know, throughout history. But I think a big part of that in terms of kind of getting that back, like you're saying, is taking ownership of your own information. And having that readily available so that you don't let those things happen to you because you actually know what's going on with your own body and kind of your own past medical history. I think the advent of electronic health records has really helped with some of that to kind of bridge the gaps, but not all of the systems talk to each other. So it is still like reinventing the wheel often if you're transferring between systems. So it gets a little bit murky, but I do think there's a lot of opportunity. There's always been talk about having one universal EHR, but I don't think that's ever going to happen. But, you know, within individual tribal groups, I think you could sort of make your own push for that type of thing. And that could be one solution, is different tribal entities decide to use one system to kind of talk. But yeah, that's just kind of
records. So a tribal entity could request records for one of their members or house it, or there's different ways to, I know there's ways to protect it, but then there's also ways, you know, that would be very, very useful as far as, you know, being able to provide continuity of care or really like transition. So yeah, that's huge. The other thing, screening, you mentioned screening, how important screening is. And I don't, you know, looking at some of the stats for New Mexico and thinking, my goodness, like, because the screening is happening so late or not happening right, it's already, you know, down the line, for whatever reason, you know, screening wasn't done, or we're seeing that that's affecting like the chances of survival and things like that. So I just wanted to, like, if you either of you could talk about like the importance of screening, the types of screening that are available. I'm not even familiar with all the types that are out there and what the importance of it. And kind of what does it look like, you know, for communities that have never, you know, had a mammogram, or, you know, what do all of these different like types of screening look like?
I can start with the community side and again pass it over to the clinical side, because I think that from the community side, it's about education to the community about what screening looks like, I guess, and there's so many different types of screening for different types of cancer. I know in some of our tribal communities, that's really important, is going directly to the community, working with grassroots organizations and departments of the tribe and providing information on screening, and then encouraging the call, or, you know, even a walk through at the cancer center to build comfort level and trust between that process. In some of our other tribes that we work with in the federally qualified health centers, we do work with clinical teams to do proactive calling, for example, on lists that are like gap lists that people have either are eligible screening and screening age and have not been screened, or they're due for a second screening and they either forget or it's just, something's going on. So our navigators actually reach out and proactively working with tribal health centers or federally qualified health centers, call and say, hey, it's time for a screening. Would you like some more information on screening? But the actual screening techniques on the clinical side, again, I think that's Michelle's wheelhouse of, what is it, how do you actually do it, and what is it like?
So I'll talk about, I guess, some of the like top 3 for our patient populations. For females specifically, it's largely breast cancer. And so the screening modality for that would be a mammogram, which is basically where you go to a radiology facility and they take a plain it's almost like a plain x-ray where they kind of squish your breasts between some plates. It's not painful, maybe mild discomfort, but it's not painful. They take an image of that and then a radiologist looks at it and sees if there's anything abnormal there that potentially would need to be biopsied or look into further. And that usually is a once a year deal. And it's also based on, a lot of cancer stuff is based on family history. So if you have a family history of cancer, say in your mom or your dad, your sister, your brother, that's significant because that could increase your risk of having cancer. So those things should always be brought to light. Another screening modality, there's actually a couple for this, but it's both therapeutic and diagnostic, is a colonoscopy. There are less invasive measures where you can do fecal blood sample, things of that nature that are less invasive than a colonoscopy. But the colonoscopy being where you actually go, it's a same day procedure where you have a little bit of anesthetic to just make you sleepy enough, not completely asleep to need a breathing tube or anything like that. But then a camera in the shape of a tube is put through your anus and then goes through your colon and then takes a look at the inside of it. People who have done it tell me after they've done it, it's, painless. They don't even remember it. The worst part of it is that you do have to do a bowel prep, which is basically where you take medications to clean out your colon so that we can actually look at the inside of your colon. But it can take out polyps that sometimes are precancerous and then can also diagnose cancer if it were to be there. But the other thing I think in our population also is lung cancer, and specifically for people who have a history of smoking, doing a one-time CT scan where you basically go in and out of a big donut when you lie flat to get a image of your lung fields will kind of be a good screening tool. So most of these, pretty much all of these are just a one-day thing. One of them takes a couple of hours, the colonoscopy, from going to sleep and waking up, but the other ones are literally you go somewhere, you're there for probably less than an hour and you go home.
So some of the highest rates of cancer in Bernalillo County, that's the county that we're in right now, and that the Health Equity Council is based out of, is lung cancer. Lung cancer is one of the, and cancer, I think, of the esophagus are some of the highest cancer, that we have here in this location. But no, thank you. That is really helpful. And for all of those, joining us or following along, just demystifying these processes for people so that this isn't something that, we shy away from, but something that we encourage. Are there mobile units, for example, for mammogram or different things like that?
That's a great question. And it ranges by basically location. I think a lot of tribal groups understand that is difficult to get patients access to these types of things. So a lot of tribes will do mobile mammographies where it's a traveling thing that will go from site to site, or even at powwows. I've seen them there too, where you can go and get your mammogram. So it's based on region and what's available. I think one of the things to kind of touch back on something that you said before about resources and having resources available is, I think one of the challenges within our populations is that a lot of these resources just aren't there. The infrastructure is not built, and then people like us have to actually build it from the ground up, which is a lot of work. And then we, are trying to do other things at the same time. So the more people we have trying to build these things and get involved when they know that there's something missing and we need to have more things, then yeah, I think that can help fill the voids.
We have a couple questions in the chat. And I know Janice here online right now. Janice she's part of the Health Equity Council. We'll go ahead and show some of the participants there. Janice, would you like to ask any questions or share anything? I know you placed some items in the chat.
Yeah, we were just talking about different kinds of diagnostic tests. And so I just wanted to encourage the panelists to share with folks to also think outside the box about the intersection of different risk factors. My sister was diagnosed with acute lymphoblastic leukemia and was sick for quite some time, but the doctors kept checking her for x-rays, MRIs, because she was having joint pain. And so just she was at a higher risk factor for ALL, given that she also had Down syndrome. And so, I can't help but think maybe if we would have gotten the blood work done sooner, instead of waiting months and doing other sorts of diagnostic tests, that we may have caught it quicker. And so, just trying to make connections between different types of risk factors that may be somewhat outside of the box or less common.
Yeah, I can respond to that. There's other tests too that you're right. You're absolutely right. There are types of cancers too that are hard to screen for. But many of the NCI designated cancer centers do have genetic counselors that can do genetic screening for different types of cancers as well, if it's deemed to be at high risk. So that's something to be, I think, for the listeners to really think about too, is there's lung CT, low dose lung CT, colonoscopy, and mammography. But also, if there's a history of rare cancers in your family, to consider getting at least a genetic counseling consult to discuss options in that arena as well.
That's a really good idea. Thank you.
And also another question too is to ask your cancer center or cancer services in your communities. Are there mobile mammography units that can come to the reservation? And usually the way that works is that it builds up some type of collaboration with the Indian Health Service clinics, and they work through contractual health to provide support for funding to have a mobile mammography reading or test done. And the same is true with there are now lung buses. Michelle, I don't know if you read the news about Roswell having the first lung bus, I think in New York, but we have a low dose CT mobile unit. It's actually like a semi rig that goes out and carries all the equipment out to remote and rural communities to do low dose CTs. But again, that's a collaboration with the Indian Health Service clinic, or seeing what health insurance covers and working in the community that way.
Brian Fernlow, one of our guests, is asking if IHS offers mammography services.
Most do, and it's in different forms. So kind of like Rodney said, often there'll be collaborations for either like a mobile unit, or there are sometimes mammography techs and services at the IHS facility itself, or they will have contracted with a facility where they usually will send people to get mammograms done.
Thank you.
This concept and this idea of ownership, like really owning our health, because I think at this point we have to ask those questions, or we have to really pursue, the additional tests and educate ourselves as much as we can so that we can actually navigate the system. If we look at research and we look at patient navigation, we look at reasons for, just in the literature and research, why people aren't getting the services or aren't able to navigate. Sometimes there's language barriers, there's different pieces, but I always think about how we can own and really kind of understand and do the best that we can to understand these different types of illnesses so that we are able to kind of navigate the systems that way. And I know you, Dr. Herring, you have a patient navigation kind of project, right, where you provide and help. I just know how difficult it is for people. We want to own and kind of understand those things, but also we need, I know there's a lot of community members that aren't able to navigate, right, or aren't able to understand or pull down the research and try to understand what's going on. I don't share this often, but I had my eldest son had leukemia when he was very young and small, and I was very young when he had that, and I didn't know anything, and he didn't go. He was diagnosed maybe a year and a half later, and it was almost too late. And the reason is I didn't know what the constant bleeding was or the bloody noses. I didn't know how to navigate the system. I didn't know how to demand that tests be done further, and it got to the point where he had no platelets left in his body or his bone marrow. And I took him probably to the emergency room every other day for bleeding extensively. And it was like, he's scratching himself, he's doing this, he's causing it. So we were always turned away until finally I demanded that the doctor do blood tests, or I am going to, whatever, a desperate mom, 21 years old. And they finally did a blood test after a year and a half, and he had, full-blown leukemia. He is a survivor. He's 22 years old. And so learning to navigate that system, living in the hospital structure, going through all of that, like I always think like how I had to kind of own it, or I had to demand, right? But that's not for everyone. That's hard for people to say, or to stand up and say like, no, there's more, I need help. Or, how do, I know you have the navigator system, so I want you to definitely talk about that project that you're doing. That's something that we want to bring here to New Mexico, but then also thinking through like how we own our own, how we can kind of like, learn more about it so that we can help navigate ourselves or take kind of control, like you said, Dr. Heiser, about, understanding what these medications are and writing it down and really doing these practices that would change the way that we receive care, we request care, and that the care actually plays out. But I'll just leave it at that and let you kind of talk about this. Dr. Harris, I know you have a great system.
Yeah, so we started out by asking those same similar questions with tribes and communities that want to learn more about their cancer care continuum, which you're describing as a continuum of what cancer means, from screening, diagnosis to survivorship and palliative care. And so we wanted to learn more about that from a quality improvement standpoint, not so much a research standpoint, but something we could give back to the communities and like attend to the gaps in the service or ways to improve what's going on, or if they were doing a great job, which many were, just give them congratulations for all the good work that they're doing. But one thing that we did notice with the nations and the community, adjacent communities we worked with, was there was a big need for cancer-specific navigation. Many health centers had like community health educators, but they're slightly different because they're not trained in the cancer care continuum and the unique and specific needs of somebody going in for a screening that could lead to treatment. So that's what we discovered. And it wasn't just our reservation communities or reserve or territories. And it was also many of our rural adjacent communities. And if you think about that, a lot of our reservation communities are in rural areas, and they face some of the same barriers in a different context, but still transportation, availability of care, understanding of that care. So it was important for us to look at, not only our communities, but our neighbors as well. That being said, too, many of our Native patients or community members leave the reservation and go to cancer centers off territory. So it's a huge culture shock medical culture shock to leave one place and go to the other, and then finding resources there or navigating within the hospital system, and then going back to the community, and then maybe working with the federally qualified health center or other safety net providers adjacent to the community. So with all that in mind, we created a program that builds out an indigenous cancer patient navigator on territory and into communities, but also in the rural community adjacent to the territories, recognizing that neighbor to neighbor sharing is important, not only for the health of Native people, but for the health of our community surrounding territories and vice versa. So to have that relationship of kind of paired navigation was really important, and it's good. They cover each other when they need to. They have meetings, they support each other. They go to events. You know, we don't stay on a reservation entirely. We go to the neighboring town for groceries or, sporting events, whatever it may be. So we're in both communities often. So it's good to have that kind of neighbor to neighbor relationship as well. And we've carried that kind of process to communities across New York State. We've worked over across borders because we're close to Canada too, that we work with our Indigenous relatives across the water. And that's kind of how we frame that program. And it's been an excellent opportunity to provide that service to our communities. I think that's a huge need for many communities across Indian country. I do know that in kind of federal conversations, Indian Health Service conversations, and some of the White House conversations about the need for patient navigation and what that looks like for Indian country.
We need patient navigation. We really need that. I do remember having a caseworker who assisted me in the hospital. So she was like their case manager, I want to say. Interesting enough, I met her again and again throughout my life. She was actually, she worked at the Robert Johnson Center for Health Policy. And so after my son recovered from cancer, I went into grad school and she worked there. She was our case manager. And now she works with the VP at the University of Mexico Health Sciences Center. But we had that case manager that could walk in the room, try to explain what's happening, chances, but they weren't able to leave that center. So the difference is the patient navigator that you're talking about is actually in the community, right? Finding resources outside of one. So we didn't have that during that time. So I just think how critical that would be to have somebody that could just walk you through all the different resources or appointments or availability, or even to be able to leave the state of New Mexico and get care, at a center like yours, Michelle, like where you provide that type of care, right? So we're so used to kind of just accepting what's right here in front of us, and what you're all telling us is that there's a universe of care. There's an actual universe of care that is looking at Indigenous health and Indigenous cancer care and making it culturally competent site, but breaking down the barriers of the state. So we're so used to staying in the state and just accepting that we're in a rural area and that's all there is to it, and there's not much for us to do, right? So we keep seeing this. People, late stage diagnosis or not getting care, or just not getting diagnosed at all until the body expires. And so there's a lot of different things happening here in New Mexico, but I just think this offers so much different. And what we really want to do is be able to model that navigation system here in the state, and to have somebody trained in that. So I appreciate you, Dr. for sharing the differences in that. I know time is going by so fast. I wanted to turn a little bit and just talk to you, Dr. Heiser, about kind of your path to becoming an oncologist. And there are very few in the nation, so it's such a pleasure to have you take the time to participate in this. And I just think that, just some of kind of your background and your advice to other young students or individuals that are thinking about or never thought about going into medicine, but how critical it is. So thank you.
I will say that as a young kid, I never thought I was smart enough to be a doctor, and here I am. So I think it was just key people along the way who sort of were like, yeah, you can do it, even when I didn't believe that I could do it myself. But I think you know, kind of going back to what you just said, is there aren't a lot of Native American physicians, and there's even less surgeons and even less surgical oncologists who are Native American. So I think there's a real need for it, just because, you know, nobody understands what we need better than we do. So I think the more providers that we can have coming from these communities and going back to the communities is really key. And I think that's, you know, the whole reason I went into medical school. And honestly, I sort of kept dodging it the whole time, because I was like, well, I'm not smart enough, I can't do that. But then it just sort of kept coming up within my life, because originally I went to undergrad thinking I was going to do like environmental biology, but I kind of got tired of being by myself all the time and I needed more people interaction. So I tried physical therapy for a while and realized I was a little too limited. So then I started thinking about medical school, and I originally thought I would do primary care for the continuity of care reason. And a lot of American Indian physicians are primary care physicians because I think we're all really interested in the community and having these relationships, and that lends itself very easily to that. But when I did primary care, I was like, why do you people keep talking? I can't help you. I just want to fix stuff. And I was very good with my hands. So surgery kind of became the next logical thing. And then it was, as I was in it, I realized there were different parts of it that could lend itself to continuity of care and cancer specifically, because it is really a journey from diagnosis, you know, the prevention, diagnosis, treatment, and survivorship or palliative care, kind of what Rodney was talking about. It's a journey, and you will see the same person multiple times in different contexts. And I think it's nice to have a relationship with people, especially in that really vulnerable part of their life, to try to explain things. And because it took me being a physician to be able to advocate for myself and my family in a medical field, in, you know, just at the hospital. And no one is, you know, you're not going to go to medical school just so that you can do that. But that's sort of the reality, is like all these things are so overwhelming, and to be able to communicate and understand things, you really do have to almost be in the medical field to have the real ownership of it. So I think to go back to like how you can really take ownership of your own information is when you do go places, have someone with you, because when you're there and you're talking about your own care, it's really overwhelming. So you're not going to absorb a lot of it or be able to ask questions. So if you have somebody there who you trust to kind of be the extra ear, also write things down all the time. And then we all have phones. So put your medication lists in there, what your past medical history is, all of that stuff. It's really important. So, but I will say, to talk to people who are thinking about going into the medical fields, I think that you have that interest for a reason, and it's going to keep coming back up. And so I think you really just have to believe in yourself, even if there's always going to be times when you don't. And I think each of us, even in really highly accomplished fields like Dr. Roybal, Dr. Herring, probably all had this, is just this imposter syndrome feeling where you were not supposed to be there, and you were probably the dumbest person in the room, and somehow you got here because they just let you in for some reason. And I will tell you, that's a universal thing, even among physicians. I think they polled like residents, and these are all physicians, like 80% of them had imposter syndrome. So it's a really prevalent thing. And I think that we are also taught to, you know, we sort of have to walk in two worlds. So there's our worlds where we grew up with our indigenous beliefs and communities, and then trying to negotiate outside of that, trying to go through the Western training world of medical school and kind of being molded by that. And I think the important thing is, like, I just can't say it enough, that we don't have enough providers to change the system. And so we just need more, because like I said before, the people who can take care of our communities the best are the people who are from those communities, because we know what we need.
Right. And Dr. Harry, you know, you have a very interesting path to this position. If you want to share some of that as well. Thank you.
Yeah, same kind of journey. In fact, I haven't shared this with Michelle or Dr. Robo. But yeah, I was going to be an environmentalist too in the beginning because I think that aligns with a lot of our indigenous ways of life. You know, it's like that is part of who we are, is to understand our environment and take care of it. But that doesn't mean we leave it. We don't have to be. Everybody has to be environmentalist, but I think we incorporate that kind of philosophy in all the work that we do as a care field, right? Care for the world, care for the people, care for the societies. And I think that a lot of my in the early thinkings and even the thinkings I have now is that in the Haudenosaunee ways of life and philosophies, we think about generations forward. We have a 7 generations way of thinking, that the things that we do now, the research that we do, the practice that we do, the service that we implement, it's not for the here and now, but it's for 7 generations forward. And how do we frame our mindsets to be that way? Well, it starts as a student. It starts as in high school. It starts as a child. It starts as a youth. To embed that thinking, and that's what I was always brought to the table, was that, well, what is my pathway? What am I good at? I was pretty good at fishing and playing lacrosse and sports and things like that, but come to find out, I was kind of smart too along the way, but I didn't think I was. I grew up in the middle of the res, and I'm still in the middle of the res. I walk the same trails I did as a kid. And that's the importance of our pathway, is to travel those journeys and understand where we come from. And, going back to the high school, but boy, I used to sit in that class right there. And, there was no way I would have thought I would have gone to Harvard Medical School, or, all these different universities, or be part of programs around the world, and I was like, boy, and I still walk through these classrooms. I got invited to speak in my high school class in the high school I went to not too long ago. And I was just, pass it every day. But that's our responsibility, right? Is to go out and do those things, remember where we come from, and be creative in your thought and mindset. It's that creativity, and kind of forward thinking and ambition and courage and being creative on how you journey that pathway that goes well above any kind of A you can get on a report card. The life experience that you have, the motivation you have to be part of your community and move forward in good ways, overcomes all of that. So
And I think moving into health, for myself, is health policy. I didn't understand what policy was. I didn't know what policy. I didn't know what health policy meant. I knew that I was in an environment with my son when he had cancer, trying to navigate. I knew there were problems in the care system. I saw people that did not understand the English language, were not proficient in English, being told very serious things, and they were okay with it. Not because they agreed, but because they didn't understand what they were being told. So I saw a lot of language issues. So, tests that didn't need to be done, or things that were critical, and the families really didn't understand what was happening and that kind of triggered, right, a little bit of the health, me being interested very much in health. And at first I was like, I'll just be a translator, or I'll just listen and translate, because if they knew what was being said, their decision might be different, right? Their reaction might be different, but I could read both, that there was an issue or some sort of barrier. And then of course, years later, lands up in health, because health is, without our health, that's everything, right? That's everything. Then education, all these other things, but being healthy, health in mind, and just well-being. I know we have a few minutes left before we wrap up, but before, I just wanted to give a few announcements. There will be a summer policy academy at the Santa Fe Indian School. And so that's for students, that's for New Mexico high school students to participate in a policy, 4-week intensive policy workshop. This is through the Leadership Institute at the Santa Fe Indian School. So this is one of those opportunities to learn policy in high school, right? Where this is really part of the Institute's initiative to introduce policy, decision-making, medicine, all these different things at a very young age. So there's a large movement here in the state of New Mexico to begin, right? How are we going to move the dial? And it's our students. And so I just want to give that information out there. It's June 25th through July 7th. You can contact the Health Equity Council. You can put my email in the chat if you're interested, and I can get this flyer out to you. The application and all of that has to be submitted by May 5th, but I just became aware of this today, and I wanted to share that with the audience here. So a summer policy academy for students at the Leadership Institute at the Santa Fe School. And so we also have a couple other projects or partner programs that are assisting students to get into MG programs here in New Mexico, but then also out of state. So any students out there or families that are interested in any part of building your education portfolio, whether it's around health or environmental or anything, we need everybody on the ground. Every single person counts. I pulled up a little bit of data a few weeks ago around STEM and women in STEM and Native women in STEM. And I found that there were only 14 PhDs in the STEM field, 14 Native women in the United States. This is a major disparity. And so I think gathering, this information, getting it out there and trying to build pathways, right, to help our students and help other Indigenous folk matriculate through these systems. And so we're here to support that. And I just want to thank you both for joining us today. Is there anyone from the audience that has a last question or comment or want to share before we go off air? Okay, so we have a couple more minutes, or is there anything that you want to share, Dr. Herring, Dr. Heiser? Any resources? I think we'll put some resources in the chat right now. The Native Circle, some information that your center has, Dr. Herring. If there's anything that you want to share or before we close or go off there.
I'll just say that we're in this together. We may be in New York or Seneca Territory or Haudenosaunee lands, but with the technology and the way things are today, it doesn't restrict us on how cancer centers can work together, how departments at universities and cancer centers that are not in that particular community can work together and align for the health of the people. And that's why I affiliate with various different universities across the country and across the world to share that knowledge, to be a partnership in that kind of 7th generation philosophy and share mindsets and keeping an open mind for collaboration. So appreciate the time to share today and keep up the good work over there.
Thank you, Dr. Herring. Dr. Heiser, would you like to share anything before?
Just again, thanks for letting me be a part of this. I think it's always really fun to see, what different Native groups are up to, because I think there are so many people who we don't always get to see each other, right? We're in different fields, but then when we kind of meet for these things, it's always exciting and kind of invigorating for me to see what people are up to and kind of the different things, and to know that you're not alone in the fight, kind of like what Rodney was saying. And there's a lot of, you're blazing the trail for people behind you. So I think if anyone's listening to this, you have a role to play in this as well. So I think that you just have to sort of identify what your curiosities are and then pursue them. So.
Thank you. And I like that. I think we're all in this together. And what happens to us here, or what happens out there, in Seneca Territory, or out here in Arizona, anywhere, any of our communities, it affects us, right? We're all in this together. And so dismantling those imaginary borders that are created by state lines, and just realizing that we're one people, and that we really have to reach out, and we're not in this fight alone. So thank you both so much for taking the time. Thank you to all of our guests that are with us this evening. And special thanks to Anna Honer, our co-producer, who is here in the background, making all of this happen. So I just want to give a special thank you to that. And next week we will be we have several shows coming up: maternal health and migration and health. So stay tuned for some of the new shows that are coming out throughout the rest of the year. So thank you so much, and we'll be jumping off. Thank you. And join us again next time.